The following is a production of Spark Study Club. To see the full video presentation and receive 1 CE credit, please visit sparkstudyclub.com and register for your free account today.
Good evening. My name is Kevin Fox. I'm a Senior Regional Sales Manager for Salvin Dental. Thank you for joining us for our March 2026 OraGen Mastermind Series. This is the session 4 that dates back to last summer, and we're excited to have you with us tonight as we have some exciting presenters that is going to be broken up into 2 segments. First will be a scientific session with Dr. Brad Wetzel that I'll introduce here in just a second. And then lastly will be our clinical presentation, the star of the show, Dr. Sean Young. As a reminder, our webinar tonight is being hosted and moderated by Dr. Brad McAllister, periodontist in Portland, Oregon. So if you have questions, feel free to put them into the chat or Q&A section, and he will be answering those as the presentation goes forward. First up is Dr. Brad Wetzel. Dr. Brad Wetzel is with LifeNet Health. He supports the clinical education and communication of the scientific foundation of LifeNet Health's regenerative biologics materials. Those technologies spread across their orthopedic, sports medicine, regenerative wound, and dental applications. He earned his PhD in neuroscience with a specialty in psychopharmacology from American University in Washington, D.C., and continues to teach undergraduate neuroscience as an adjunct professor at the University of Maryland. Prior to joining LifeNet Health, Dr. Wetzel held roles in the pharmaceutical industry, helping to design phase 1 first-in-human clinical trials and report their results to the U.S. FDA. He is currently an author of more than 20 peer-reviewed publications. So please join me in welcoming Dr. Brad Wetzel for our scientific presentation.
Okay, thanks, Kevin. And thank you all for joining us. It's a pleasure to be with you here this evening and an honor to co-present with Dr. Young. We thought it would be useful just to sort of run through a quick overview of the science behind OraGen. And I'm going to run through these slides very quickly because I want to give Dr. Young as much time as possible. But if you have any questions that come up along the way, please just stick them in the Q&A and we'll get to those at the end of the evening. So I always like to begin this discussion just sort of reviewing the bone biology basics, the normal sort of bone resorption process that happens naturally in our body. For me, it's a cyclic process, of course, but for me, it starts when the osteoclasts bind to that bone matrix and release hydrochloric acid and begin to dissolve that bone matrix to free up those minerals for use in other areas of the body. Of course, the beauty of that is that embedded within that matrix are many growth factors like the BMPs that we all know of and many others that sort of serve like sticky notes to remind the body to come back and build backbone where it was taken away. Those growth factors stimulate mesenchymal stromal cells, or MSCs, to differentiate into osteoblasts and recruit them to the site where they can then reattach to the bone matrix and start laying down new matrix where it was taken away. Easy stuff, right? This takes us back to undergrad anatomy and physiology. But what we can garner from this is that there are 3 essential processes that we need to provide whenever we have a defect that we want to heal in bone. We need an osteoconductive scaffold where all of that work can take place. We need those osteoinductive signals that promote the bone growth, that recruit cells to come to the site. And then, of course, we need those actual osteogenic cells that come to the site and start laying down bone matrix. Now, we also know that there are a lot of clinical considerations that can impede this process. These can be patient-related systemic illnesses like diabetes, osteoporosis. They could be lifestyle risk factors like smoking, malnutrition. They can also have to do with the defect itself. If it's a large or complex defect, if we have not so ideal fit and forces of an implant or inadequate bone bed preparation. So the more of these things, these risk factors that we bring to a case, the more we might become interested in supplementing a patient's body's ability to provide those 3 components of bone healing. And one of the nice things about allograft options is that we have a wide range of options that, depending on how they're processed, can provide anywhere from 1 to all 3 of those. So for the simplest ones that just provide an osteoconductive matrix, like our allograft, traditional allograft bone chips in cubes, all the way up to our more advanced things like you see with osteofiber, osteofiber plus, advanced demineralized bone matrices, and then our most advanced bone grafts such as OraGen, which are bone cell-based allografts that are able to provide all three of those factors. So CBAs, as I said, can provide all three of those factors. These come in a couple of different forms. Most of them that are on the market work on preserving mesenchymal stromal cells or MSCs or stem cells. But OraGen is unique in that we have focused on preserving lineage-committed bone-forming cells that can hit the ground running and start developing bone matrix as soon as it's implanted. It has two different components. First, it has corticocancellous chips that are recovered from areas of the body that are known to contain live bone cells. So this component is able to provide the osteoconductive and osteogenic properties. It also helps provide a little bit of space maintenance, which is often important in dental applications. And then it has a second component that's demineralized bone fibers. These are fibers that are precision milled and have little micro hooks on the end of them that bind together sort of like Velcro, which gives it its handling properties, its moldability. And this, of course, because it's demineralized, is providing the osteoinductive potential. So why is it important that we preserved lineage-committed bone-forming cells? Well, with MSCs, they still have to differentiate into lineage-committed bone-forming cells, and they can actually differentiate into any number of cell types, many of which are displayed here. And which path they take is really dependent on a very complex set of local molecular signals that can vary greatly from patient to patient, especially in a patient that has the sort of risk factors and comorbidities that we've been talking about. So that means that these can differentiate into unwanted cell types, which can slow down or complicate fusion. The other downside to these is that it takes 3 to 4 weeks for that differentiation process to occur. So that's 3 to 4 extra weeks of healing time, 3 to 4 extra weeks of relying on patient compliance, which of course is never a problem. And so what we decided to do is, hey, if the goal is to build bone, why not focus on preserving lineage-committed bone-forming cells that can hit the ground running and start laying down bone matrix practically as soon as they're implanted? So how do we know that we did that? We conducted a whole slew of characterization assays, and we actually published a paper, my colleagues and I, a couple of years back, where we outline all of the different characterization assays that we did. But I think this is probably the coolest, most telling one. This is what we call the alizarin red test. Alizarin red is a substance that turns bright red in the presence of calcium. And so what we did is we took a Petri dish and impregnated it with cells from OraGen. It's important to note here that when we do these tests, we always do it with the final product, the same product that you're going to have in your hands in the operatory. Many other tissue processors will try to perform these tests at different stages of processing, like before cryopreservation. But it's important for us to make sure that we do this with the same product that you're going to have in your hands. And you can see in the upper two sets of panels by day 7, we already have some bright red there showing that those cells are already starting to lay down bone matrix. By day 14, it's nearly confluent in the dish. And by day 21, you can see in the lower left set of panels, it is confluent in the dish. So this really is showing us that these cells are ready to go. They're starting to lay down bone matrix as soon as they can. We did the same test with MSCs. You can see by day 7, nothing. By day 14, maybe a little bit of a pink hue, but certainly nothing to the degree that we see with the OraGen cells. And this, of course, stands to reason because, of course, you know, as we said, it takes 3 to 4 weeks for those cells to differentiate to a state where they're able to start laying down bone matrix. So this really, I think, illustrates nicely the advantage that you have with using a product like OraGen because these cells are ready to go practically as soon as they're implanted. Now, you may be wondering about safety because, of course, we cannot sterilize this graft. It has live cells in it. So we would just be killing the cells that we've worked so hard to preserve. It's important to know with this that LifeNet Health has among the most stringent screening criteria, donor screening criteria in the industry. We can afford to do this because we have the largest recovery network of any tissue bank. Normally with our screening, once all of our donors are tested for each piece of tissue that's recovered is tested for contamination. Every donor goes through serology testing for known viruses. Once we go through all of that testing, we usually accept for most of our grafts less than 2% of eligible donors for clinical use. In the case of OraGen and other viable grafts, that goes down to less than 1%. So because we can't do the sterilization at the end, we really sort of beef up the screening criteria in the front end to ensure the safety of our patients. It's important to know that since adopting these screening criteria, LifeNet Health has distributed well over 12 million grafts across the globe, including over 400,000 grafts of Vivigen OraGen without a single instance of disease transmission. So we really do have a stellar record when it comes to safety. OraGen has a history of success. This was originally introduced way back in 2014 as Vivigen in the spine space and has gone through in the trauma, foot and ankle, and CMF space. And then last year, we introduced it with Salvin as OraGen in the dental space. And that's all I have for you. So from here, I will turn it over to Dr. Young to hear about some of his cases with OraGen. Thanks.
As I mentioned earlier, we're really excited to have Dr. Sean Young join us tonight. Dr. Sean Young is a Tampa native. He was born and raised in Brandon, Florida. He then went to Gainesville, where he would play tennis for the Florida Gators. He then attended the University of Florida College of Dentistry before headed to Emory in Atlanta for his oral surgery residency. He is married to Dr. Valentina Espinoza, who's a dentist as well. He met her at the Florida Dental School. He has exceptional surgical training and exposure to multiple community hospitals serving diverse populations. His surgical expertise includes dental alveolar surgery, implants and bone grafting, orthodontic surgery, maxillofacial trauma, and reconstruction. He has a strong passion for helping others. He's a member of the American Association of Oral and Maxillofacial Surgeons, as well as the American Board of Oral and Maxillofacial Surgery. But probably most impressive to me, he's an avid runner and a triathlon competitor, having completed a half Ironman. So please join me in welcoming Dr. Sean Young for our clinical presentation.
Thank you, Kevin, and thanks to Dr. Brad. That was a great introduction from the scientific standpoint. Really helped me out with going through all that stuff, and so I could just get to go to the fun part and show all the cases. So, yeah, good evening to everyone, and thanks so much for tuning in. I know everyone always has a lot of things to do on a Wednesday evening. A lot of us have kids and families, and so I appreciate everybody tuning in. I think what I really hope to display through these cases is sort of the indication of when and how I've decided to use OraGen as my bone product in a lot of these cases. And I think most importantly, what I find is that there are a lot of cases where maybe harvesting autogenous bone is just not ideal from a medical history standpoint of the patient or just the bone availability that they may have in the posterior mandible, whatever the case may be. And so it's been really exciting to have the first basically cellular bone matrix in dental surgery now, where we actually have an osteogenic part of one bone graft, right? So we've never had a grafting material where you can get all three properties that Brad mentioned previously. So I do want to really acknowledge Salvin and thank Christy, who's my local rep, and Steve and Kevin and Greg. They've just been really monumental in my growth and a partnership with Salvin and all of their products. And so I appreciate their invite, and I'm looking forward to showing you guys some cases. I don't have to dive into too much of the scientific part. If you guys have any questions, feel free to ask Brad any more questions, and I'm gonna kind of show you guys some of the cases I've used where we've maybe just used OraGen alone, when we've used OraGen and maybe some additional, Salvin cortical 70/30 or mixed it with anything else. And we'll kind of go through that and show you why we've chosen to do that. These are my co-chiefs here in the front from Emory University. We were the best class at Emory. We finished in 2017. And then my lovely professors and attendings up top. And I'm just forever indebted to them really for the training that I received. And while we really didn't have much of a dentalveolar surgery or implant reconstruction practice, the foundation and skill set that I was able to learn while doing really complex trauma, TMJ, orthognathic surgery cases, I think really set the tone for being able to do the types of cases really that I focus now in private practice. Recently celebrated my 40th birthday, and these are all the guys that, as many of you know, who are oral surgeons that have just gone through the grind with your co-residents, and they all joined me in Tampa a couple months ago to celebrate my 40th. So these are some of my good buddies. Hopefully, some of them are on tonight. These are the guys that I currently practice with. There's four of us at Mosaic. We have four practices in the Northwest Tampa area. We're about 15, 20 minutes northwest of the airport, and we go as far south as Clearwater and all the way up to Newport Richey and out east out to the Land O'Lakes, Lutz area. And I always acknowledge my partners because it's great to be in a practice where I have other young surgeons that I can go to the operating room to do some of these more complex cases, or at least bounce ideas off of them when we have, difficult cases or difficult patients. And now I have been traveling more and speaking more and doing more of these educational type things, and they always hold down the fort. So, um, definitely feel free to ask any of the guys that were on here previously, about OraGen and how it's shipped and the cost of it. I think this, I'm not even sure if this is still accurate. This may be outdated now. But I'm going to kind of show you guys how we've done it. We now have a cryo freezer in the office. You can order this OraGen and typically it can get to you within 1 to 2 days. And it comes in a cooler with dry ice. And I think you just have to use it within, I want to say, 48 to 72 hours. The Salvin guys can correct me if I'm wrong, but we've since kind of committed to the product because it's proven itself. And so we now have this cryo freezer that was provided by Salvin and LifeNet. And so now we're able to store these, which has just been fantastic because sometimes you'll plan a big case or you have a big case on Monday, and it's really difficult to order this product and have it get there on Monday morning in time for your surgery, especially if it's super early. So I think if you try the product and you believe in it and it works for you, then it's probably worth investing in one or partnering with Salvin to get one, just because you have it readily available. And I'm going to kind of show you how it's saved me in a couple of my cases. So when Christy, my rep, came by to the office and first introduced me to OraGen, and I had known a little bit about it just because it was previously distributed, or I guess it still is, by Synthes, sort of on the medical side of things. I have some colleagues that have used that in the operating room to reconstruct segmental defects from maybe tumor resections and have had really great experiences as far as bone regeneration. And so when she told me about, hey, we have this new product out and it has all three properties and it's got viable bone cells that are committed to forming new bone, I immediately thought of this case when this is a patient that came to see me, probably lives about an hour away, and she had previously already had multiple bone grafts to the posterior left mandible. And so she actually came in and told me, hey, I think I need a hybrid because I want teeth in the back and I've already had three failed grafts. And so I definitely am not going to go through another graft. So I just want to know what my options are. And so initially, I talked to her about her options, which of course, looking at the three implants she has on the right mandible had been in there for so long, I really didn't want to mess with those. And so I said, well, we could take out 22 to 27. They're really not that unhealthy. There's a little bit of bone loss, but they were stable. There was no caries. She obviously has a significant defect in the posterior left mandible, and so discussed with her possibly placing 3 to 4 implants. Although there's probably not enough current bone height in the posterior to get an implant behind the mental nerve, and so we'd have relatively long cantilever. So just after discussing the case with her and giving her options, I said, look, why don't you let me try to graft it one last time? I haven't grafted it yet. If for some reason it doesn't work, whatever you've paid for the graft, I'll apply towards a hybrid, and we can do that if you choose or want to go that route. And so one of the things to note about these patients and some of the patient selection, and I guess I'm going to talk about it a little bit when I show you some of the photos here. But keep in mind here, whenever you're selecting these cases, we can't overestimate how much vertical gain we're going to be able to achieve because we have to pay attention to the biology of what the patient has, and we're never going to grow more vertical bone than what the adjacent bone is that's already present. So if there was significant bone loss on the distal aspect of that canine, that's a tooth we'd probably would want to consider extracting just so we can get height up more coronal on that mesial aspect. But she had pretty reasonable height here. The tooth was completely stable. There's no mobility, right? And so this is kind of what she looked like. And you can see the tissues fairly scarred down. She's got a high muscle attachment that's attached to the ridge. One of the things you can't appreciate in this photo is this was a fairly large patient with a very big tongue. And so her basically the floor of her mouth was almost attached to the ridge, even on the lingual side. And so given that this was I'm not exactly sure what type of grafting or how it was done previously. I talked to the patient about why don't we try to get some better quality tissue. Let's release those muscle attachments so we have a little bit more of a vestibule, which may help us as far as grafting. So the first thing that we did was actually a free gingival graft, just to try to increase that zone of keratinized tissue, try to deepen the vestibule a little bit. I'm not a periodontist. I think this is probably a reasonable free gingival graft here. Some of the periodontists can maybe comment on it. Um, to be completely honest with you, it didn't heal quite as nicely as I would have liked it to. I definitely didn't have any mobility of the graft. Perhaps just the patient and their body habitus and whatnot, just didn't have a very favorable environment. But at least we've deepened the vestibule here, and we have certainly a couple more millimeters of keratinized tissue. So here's the OraGen that this was the very first case that I used OraGen in, and it comes in this really nice freezer. I'll be honest, they say you're supposed to use within 1 to 2 days. We have that cooler of dry ice, and we've had some like, even though we've used the product, we keep the cooler there, and there's a ton of dry ice, and it stays there for probably a week. So they really ship it very nicely. It comes completely frozen. It's like -70 degrees. And then your local Salvin rep can come and help you thaw it out. But this is basically the patient's ridge. They didn't have a significant, it wasn't such a large horizontal defect. It was mainly just such a big vertical defect that there was no space above the nerve to try to put an implant, behind the mental foramen. In this case, we used a 1.3 cc of OraGen, comes in both 1.3 and the zero point 0.7. As I've done more and more cases, I kind of prefer to mix some of the OraGen with the Salvin 7030 just to get some more of the corticocancellous or the cortical chips. So we actually use the Min D-Min 7030 cortical. And so this one actually all we used, I was able to scrape a little bit of autogenous bone and I mixed it with that 1.3 cc of OraGen. And we just kind of packed it here, just your traditional sausage technique with some tacks, and we were able to get a pretty good amount of bone kind of packed in there. And you see a little bit of PRF over top. And even in a case like hers, primary closure was tough, but we were able to get it released enough that we were able to get primary closure without any tension. And the biggest thing that I learned after doing this case, which I was very surprised at, I see all of my patients 2 weeks post-operatively. I saw the patient at 2 weeks, and when I looked at the ridge, I don't have a picture of it, but it was already felt kind of hard. Like the ridge felt dense, which is unusual. I think usually you see these types of grafts, you see them a couple weeks after surgery, and the tissue is still kind of puffy, even if it's closed, it's almost a little bit spongy. But I was surprised at how firm the ridge had already felt at 2 weeks. And so I kind of knew right away, like, man, the tissue looks awesome. Like I can already feel the ridge. Like this is gonna heal really well. At that point, I had already said, all right, like I'm in. I started planning some more cases with OraGen. So this case, I think we've done almost a year ago now. So anyways, we went back in at 5 months. I think the other thing that we're seeing with this product is, usually in some of these larger ridge augmentations, especially if there's a vertical defect, we usually wait minimum of 6 months. And we're going in, and I'm going to show you a pretty impressive case at the very end. I think that slide that Dr. Brad showed about the calcium deposition and early bone formation is I've seen that firsthand as definitely a real thing. So we went back in, and you can just notice the bone that's been regenerated here. You can see where that posterior tack is all the way in the back. And I just have this massive mound of bone. And I think the thing that surprised me the most was I've done some GBR cases with autogenous bone only, and this bone was almost it was more dense, I think, than autogenous bone. You can just look at the quality of it. It was rock solid. Beautiful ridge formed. We got about 3 or 4 millimeters of vertical gain, with all resorbable materials. And we were able to get, I think that's a 4.2 diameter in the front and a 5.2 diameter in the back, planning for a 3-unit bridge. And this is just a collagen matrix I placed on the facial just to try to thicken the tissue a little bit more. And then we placed healing abutments. And what you can actually see in this Panorex is for that number 19 implant in the back, I wasn't able to get my implant all the way down to where how deep I got my osteotomy. And that was just because the implant was torquing so high, it got to a point where I couldn't torque it down anymore and I couldn't reverse it out. And I was afraid that I was gonna, you know, tear off the end of the BioHorizons driver or strip the implant. And so that's what you can see there, why the depth of the implant. I would have liked to place it slightly deeper. I just couldn't move it anymore because the bone was so dense. So anyways, if you look at the top Panorex and kind of where we were pre-op, sometimes if you look at the bottom one, you're like, oh, well, that doesn't look like this that significant of a vertical gain. But if you kind of look at where those implants would be if we placed them bone level, without augmenting it, that we'd have a massive, massive crown to implant ratio, probably would create really big food traps, right? And so one of the other things you can see on the bottom Panorex is how the top almost looks still a little bit loosened. And we see this sometimes in some of these bone materials. And over time, it certainly will continue to ossify and calcify and get more dense, and it'll get more radio opaque. This was, I think, a month out from her surgery. She's still waiting to get restored. I think the general dentist has had some issues with the 3-unit bridge and whatnot. But notice here in the most recent Panorex, you can see that all that bone has kind of filled in underneath the apex of that posterior implant where I wasn't able to get it any deeper. But bone looks really good, and the patient's just thrilled because she had already made up in her head that she was likely going to have to get the rest of her teeth taken out. So this second case is a lady in her, I think I want to say mid 60s, who is missing all of her teeth posterior to number 11. You can see also has a relatively low sinus. And so for a lot of these cases, I like to do an open sinus lift and a rigid augmentation simultaneously. She actually needed that number 11 tooth extracted. I think she had recurrent decay that was subgingival. So we removed the tooth, and at the same time, we did an open sinus lift, which you can see here via lateral window. And in this case, we used OraGen plus Salvin, the cortical 7030. Some of the chips you'll see in the OraGen, I think, they're now a little bit smaller, but some of the initial batches, I think you'd see some of these larger bone chips, which you can kind of see within the graft itself there. It's also very easy just to take a ronger or something like that. You can kind of clip those if you want to make them a little bit smaller. So sinus lift was done. We augmented the rid simultaneously, put a collagen membrane over it. Almost always we'll use tacks and or sutures, sometimes a combination of both. And then, of course, the most important thing is making sure we have tension-free primary closure. These are 5-0 glycolon sutures. And here you can see the immediate post-op Panorex. I tend to get a lot of imaging in my cases. Sometimes I'll get a post-op pan, sometimes I'll get a post-op pan and a CT or just a CT. For me, it's a great opportunity to evaluate what the graft looks like immediately after surgery and then how it looks 4 or 5 months later when patients return for the CT scan. Because then you're able to determine which products that you're using, whether it's you're trying to determine which bone, which membranes you prefer, which materials did I use, is the graft staying around, is it resorbing, am I regenerating new bone? So that's just something that I've been doing for years now, and I really like it because it helps me to compare different products when I'm doing surgeries. So I think for hers, we went back in at 6 or 7 months afterwards. Here's just a sagittal shot on the left, and you can kind of see the CBCT on the right side. We gained a lot of width, got some great height, and so we regenerated a lot of really nice bone here for these implants. So we basically wanted to restore her back with her number 11 and then do a bridge from 12 to 14. So we put in three BioHorizons implants here. You can see them placed here. And then we put a couple smart shape healers on the front, just a traditional stock abutment in the back. And then again, just another porcine collagen matrix here just to increase our tissue thickness and zone of keratinized tissue at the time of placement. And this is immediate post-op, and she's about 6 weeks out now. She's healing beautifully, and I'll probably clear her in the next 6 weeks. Okay, so this is our third case here. This is a lady who was in her 50s. You can see had a couple retained roots in the premolar area, and then a very, very knife edge ridge. And to be completely transparent, this case had kind of crept up on me, and I wasn't exactly. I didn't know this surgery was scheduled the day that it was. I had a hybrid that same morning, and this was the case immediately after. If you kind of look at that defect, you said, "Man, this defect is a little bit worse than I thought it was going to be." So normally, I think for something like this, I'd probably maybe plan for, like a custom titanium mesh or something non-resorbable, just because of how narrow the top of that crest was. Thankfully, at this point in time, we had our cryo freezer and we had OraGen stocked, and so I was able to use this. And I was, as you'll see here, I was more impressed with the outcome than I thought I would even be able to get. This is the Salvin Renovix membrane. Typically for these types of defects, I'll always use the 30 by 40. I always tell surgeons and colleagues, always use a membrane that's too big and trim it back. I have always tried to be stingy in the past and, oh, let me try to see if I can get away with a 20 by 30. Then it's not quite big enough. It doesn't contain your entire graft, and then you're having to use a second one, and then it becomes more difficult to stabilize it. So for these posterior defects, a 30 by 40 almost always is enough if you're going from first premolar all the way back, like it'll be long enough. And then I always kind of do almost like a C cut of the membrane so I can wrap it anterior to the mental nerve. I always tack it there first, as you can see in this photo, and then it sort of wraps around the most distal tooth, and then it'll go back onto the lingual side. But we're making sure we're basically creating a pocket where we can pack the bone, but we're making sure that our membrane goes beyond the actual defect that we're grafting. So first we sort of tack. I usually use three tacks on the buckle. I'll tack it first anteriorly, then all the way in the back, and then I'll put one mid buckle. I call it like a pocket. So we now have a pocket where we can take all that graft and really pack it in there. This was another 1.3 cc of OraGen mixed with probably a 0.5 cc Salvin 7030 cortical. And you can see it's all packed in there very nicely. And then I use a 5-0 glycolon suture for these periosteal sutures. Usually two or three is more than enough. And that's just a horizontal mattress from the lingual. It's a periosteal bite on the buckle, right where we've made our periosteal release. And then it re-enters through the lingual side, and then that horizontal mattress is tied there on the lingual. It's a double layered closure, usually some horizontal mattresses with that 3.0 PTFE, and then either simple interrupted or just a continuous. Always very important to first reattach your papilla sparing vertical release first, because if you try to just suture everything over the grafted area first, you will overstress that tissue, and then you won't have enough tissue to reapproximate your papilla exactly where it was supposed to go. And then that most distal tooth will have a pretty big, recession defect. And then so we went back in, she obviously has a very, very, almost non-existent zone of keratinized tissue. I actually did this case a few weeks ago, but just I was pretty blown away at how much bone we regenerated. Again, this was all just with OraGen and resorbable materials. I didn't have to use a mesh, like, I mean, this is, no titanium reinforced PTFE. We got a beautiful thick ridge here. We got our two implants in. I think we did a 3/8 in the front and a 5/2 in the back. And just really nice, good dense bone, as you can see. I mean, there's no, there's no foreign material, granules that look like they haven't turned over. This looks like really healthy. It has a very similar appearance to pure autogenous bone. And so we buried these implants. I'm planning to let this heal probably for a couple months, and then I'll do a free gingival graft to deepen the vestibule and get us a nice thick band of keratinized tissue. So you can kind of see where we started here, and then the regenerated ridge. All right, and I was having this conversation with Dr. Brad earlier. And, one of the things, at least in my cases that I've used it on is I've really wanted to truly test the material and how well this graft works. And so a lot of these cases that you're seeing are cases that grafts have failed previously, or they're just very difficult cases, not your sort of bread and butter, slight ridge augmentation case. And so, while some of these cases are a little bit more atrophic or maybe complex, I'd encourage you guys, especially using it for the first time, try to use it in a case that it's not like a knife edge ridge like the last one. It's not a third time trying to graft a case type thing. You want it to work. The product works great, but maybe pick and choose your initial cases wisely until you kind of get used to the handling of the product. This is my own complication of a case that a patient came to me missing 7 and 8. I got him into ortho. The spacing was inadequate, so he went into Invisalign for about 6 to 9 months. And then he came to me and he was ready for the grafting. And so the initial technique that I used was a split bone block technique, which I don't have a ton of photos in this presentation just due to time. But essentially, what I had was part of the block had gotten exposed on the facial. You can see where that screw head is. And so the graft pretty early on had basically failed and the tissue thinned out. And I think my blocks were probably too thick and didn't vascularize well. And the tissue, maybe I overstressed the tissue when I released it. So I said, well, let me see if I can take all this stuff out, get those screws out, and we will try a second time with OraGen. And so here you can see like one of the blocks is kind of up top, and then there's another piece where a lot of that had gotten exposed and resorbed. So luckily we have pretty good bone peaks on the adjacent teeth, but certainly a vertical defect in the middle. And so we tuck this collagen membrane there on the palatal first. I think in this case I just used a zero point 0.7 cc of OraGen. You can see the corticocancellous chips. You can see the demineralized fibers all in the one graft material, and then just periosteal sutures to secure the bone and the membrane together. Where the two sutures you're seeing on the front there, that's kind of where you had a little bit of a soft tissue dehiscence from where the screws and where the block had dehisced. So that's why you're seeing those two sutures there. We got enough release. You can see we have the papilla lined up on either side there for teeth numbers 9 and 6. And he's doing great. He's healing well. He's now a couple months out. This is just a 2 week post-op. You can see the tissue looks very nice. It's very healthy. We got nice thickness there. So he'll be coming back in really soon to finish up his implant surgery. But really pleased with the result. You can see what his defect was preoperatively after the failed first block, and then this is how the graft is looking right now. So things are really looking good, and I'm happy, and he's happy, and we'll hopefully get the implants and some provisionals in there in the next couple months. Okay, case 5 here. This is another posterior mandible case that I want to show you guys. I find that posterior mandible defects are probably the most common areas that we get asked to augment. I think just people lose their molars maybe early on, and for a while they financially can't, they didn't pay to replace those teeth at the time or do any bone grafts, and then years later, they get more financially stable and they decide that they're ready, to get some teeth back in. So again, here you can see not a significant vertical defect. The crest itself is relatively thin. Luckily, in this case too, the patient had a nice band of tissue you can see here to start, which we don't always see in some of these cases where patients have been missing teeth for a long time. It's always a papilla-sparing vertical release in the anterior. I've shown this technique before, but when I do my periosteal release, I always start it right over the mental nerve because that helps me to know the depth of my release. And it's one of the things I think surgeons get wrong sometimes when they're doing this release is they're too deep. The periosteal release is very, very superficial. So if you find the mental nerve, you dissect down and you start your periosteal release 5 to 6 millimeters coronal. It's very superficial until you start to see the branches of the mental nerve, which you can see in this photo. And once you're kind of through that very superficial layer of the periosteum, you're just extending that release all the way from to the front, vertical release, and then connecting that all the way to the back in the same plane. You should not see muscles. You should not cut through muscle. This is all through periosteum. If you see muscle, you've already cut through the layer that you're trying to stretch. Um, and so I think this is probably the most important thing, about having success in these grafts is really making sure you have proper soft tissue release. I'm just showing this little video here. What you're seeing with those forceps is that's the periosteum and where we're making that release. And so my Minnesota is on the superficial part that we've completely stretched out. You're seeing the three tacks there, the one in the anterior, the middle, and the back. The periosteum that you see laterally is where we will suspend our periosteal sutures. So I'm a big Urban fan. Unfortunately, I can't operate like him, and so I have a very difficult time tacking the lingual. And so for me, what works well is putting three tacks on the buckle, creating a pocket, stuffing as much bone as we basically can. Always want to overpack because we know we're going to get some resorption, right? And then I tend to tuck my membrane then over the lingual, and then I'll use the periosteal sutures to stabilize the crestal aspect to make sure that the whole graft membrane complex is completely stable. So here you can see the OraGen. Again, I think this was probably another 1.3 cc mixed with a half cc of the Salvin 7030, and the membrane's tacked already on the facial. And in this case, we use three horizontal mattress sutures with the 5-O glycolon. And so it's attached to that periosteal layer inferiorly, which is usually slightly more apical than where the graft is, right? We want that suture to be suspended beyond where the bulk of all that graft material is. And then this is again a 30 by 40 Renovix membrane. So the whole complex is now very stable. And you can see here, like once we do those horizontal mattress sutures, which you can see on the facial, which is really closing the deeper connective tissue layer. It's about 5 millimeters from the edges of the wound. Essentially, the tissue should be closed, and then it's just a continuous running or a simple interrupted. I've been doing more now, just running it just to do it faster. There's really no tension. You shouldn't be pulling those sutures to close the edges of the wound. That's just making the edges close over, but you really shouldn't have to pull very tight. If you are and you're having to use that last one to really close it, probably don't have enough release, and then there's more risk of it dehiscing. You can see how everted these edges are. And again, I think the thing to note here, right, we have basically a mild but a concavity there on the preoperative Panorex, and you can see at the bottom X-ray about 5 months later that we actually have a mound of bone that's almost a straight or even a convex appearance now to that Panorex. And so we went back in. I guess the one thing I want to show you before that is, and I talk about this frequently, is technique is greater than biomaterials, right? While OraGen is an amazing product, if we don't have the foundations of a proper soft tissue flap release, stabilizing the graft, it doesn't really matter what materials you have, you're not going to get the consistent results that you want. So that's just something that, I want to make sure everyone's aware of is, I think it's really important to make sure you follow those past principles, you follow the techniques, and you make sure that you're doing all those important steps. And then that way you're going to have a much higher success rate of these grafting these cases. So we went back in 5 to 6 months here. Again, you can see really, really nice thickness to that bone. Very dense. I've always gotten really good rock solid primary stability on all these implants. And, again, I show this those osteotomies and then the implants. And, this type of bone, it just heals different. I think it looks different. It doesn't look like just like a case where you're using allograft and maybe xenograft. I think this looks much more like autogenous bone. This is actually a case that I grafted a couple of years ago with just 100% autogenous bone using a bone scraper, and you can see how similar in appearance that is. You don't see any gritty foreign material that's still in there. It all looks like very healthy, vital, natural bone. And then again, I do this technique a lot, but I use a porcine collagen matrix kind of at the time of implant placement. Sometimes we can use this to increase the tissue thickness and get away from not having to do like a secondary free gingival graft if possible. So this patient's now a couple months out, healing well, and will be cleared for her restorations soon. So that's where we started, and that's the bone that we were able to regenerate with OraGen. Okay. Okay, a couple more cases here. This was a case this guy presented to me early last year, and he kind of already knew that he was headed towards a hybrid. Of note, he's got that implant bridge on the lower left, which was done a couple of years ago. It was completely stable. There's maybe some very mild crestal bone loss, but there was no threads exposed. You can clearly see that the implant and the number, I guess 30-ish position with significant periimplantitis, tons of bone loss, right? And so it's basically almost touching the mental nerve. And so in planning for this case, I said, well, I really would like to try to graft that area first because even if I were to try to get an implant anterior to the foramen, we wouldn't be able to get it very distal because of all the crestal bone loss that's around that implant. And so I said, listen, let's first remove that implant. Let's graft it. Even if I can't get enough vertical bone to place an implant axially posterior to the nerve, I can at least regenerate some healthy bone that I can try to distalize my angled implant a little bit more posteriorly and hope that it would sort of emerge by the second premolar. So this is the implant the day that we went in. And this was just taking it out. Obviously, it was very easy to remove. There's a significant vertical defect there. I didn't capture it great, but if you look right where the implant was and you look a couple millimeters down, that's actually where the mental nerve was. So the mental nerve was only 2 to 3 millimeters below where that lowest point of that bone was on the facial, where that implant was failing. This is my PerioPro picture for all the periodontists here watching. Pretty big defect here that we're trying to regenerate. Again, it is helpful that we have a pretty decent bone peak on the distal aspect of that tooth number 28. So I did my same, technique with a collagen membrane, put 3 tacks there, created a pocket, packed. This one was an OraGen only case where I just used the 1.3 cc's of OraGen, tucked it in, got primary closure, and this was the immediate post-op Panorex. So a couple things to note here, right, is one is how dense and nice that material looks immediate post-op, right? And then we're gonna hope, we said, okay, well, if that graft takes, that's pretty good. Like we'll have a pretty significant gain in the vertical bone. Here's his teeth. Obviously, you can see significant periodontal disease, poor oral hygiene, 22 to 27 basically shot. His implant bridge was pretty healthy. So we actually ended up using the implants he had on the lower left because due to his vertical, we had enough thickness in those teeth. So while if I would have planned this case from scratch and he didn't have existing implants, we probably would have tabled the bone a little bit more. We were somewhat limited because of the position of the implants in the back in the 1921 area. But you can see in the clinical photo, there's healthy tissue around those implants. So all I did was just remove those crowns and put some multi-units on, and I used those 2 existing implants in the back. Here we re-enter, I think 8 months. Actually, it wasn't 8. It was closer to 6 months later. Really, really nice bone. Here you can see this is the anterior implant that's anterior to the frame in there. And here you can see where I put my tack. You can see where the mental nerve is. And we almost got probably about an 8 to 9, vertical gain on this case, and I was pretty shocked and surprised, to be completely honest, that the bone regenerated as nicely as it did. We were able to get a really nice implant and basically the number 30 area axial implant. You can see we got some nice tissue thickness there in the back. So we added 4 more implants for his lower hybrid. Here's the immediate post-op CT, and if you compare where I lined up on the CT scan, well, let me line up right where the mental nerve is so I can actually compare. You can see he only had about 2.6 millimeters of bone at the center aspect of the existing bone. Once we remove that implant, you can see all the graft material there, immediate post-op, and then you see the 6 months later how much of that bone has really turned over, remodeled, and regenerated into really nice, healthy bone. So close to 8 to 9 millimeter vertical gain here. You can see that if you look at the nerves here in both of those photos. And then again, like the bone was super dense, probably got 40 to 50 Newton centimeters of torque when I put that posterior implant in. You can see all the multi-unit abutment and the caps on top. And then just note like how the top or that crestal aspect of that bone still looks a little bit lucent at the time of implant placement. And then you can see it now. I actually just delivered his final prosthesis last week, but that bone level on the right side is almost at the same level as it is on the contralateral side. So really nice case here. We're able to regenerate a pretty significant vertical defect. Now this guy has hopefully set up for a really nice long-term lower hybrid, and hopefully he signs up for the upper soon because he certainly needs it. Okay, I like to show this case. I haven't gone back and put the implants in yet. For me, I see a lot of these patients with congenitally missing lateral incisors. Traditionally, I would always use a ramus block to graft these because I just think it fits perfect. You don't have to take a huge block. These patients, it's just a nice fit. It's very predictable. It's certainly a second surgery site, right? There's always a risk of injury to the nerve if you're taking a block from the ramus. But have now done enough of these cases where I feel confident in just grafting these alone just with OraGen. And so this is the case. You can see there's certainly a pretty significant horizontal defect here. And here we just use a zero point 0.7 cc of just OraGen by itself. And then just the same kind of technique that you've seen in the other cases. We first tuck or tack the membrane on the palate first, pack it deeply on the crest. Even some of the bone goes on the palatal aspect of the ridge. Then we pack it on the facial, flip it over, and then either tack it or suture it here. Again, I think this one, I probably use a 20 by 30 Renovix, which you would say is probably big for this site. But again, I like to have a bigger membrane and trim it back rather than not having the entire graft covered. So here's the Renovix. You can see the tacks on top, really nice and tight. Everything is completely stable there. So, this is going to heal really well. There's no reason why this isn't going to heal beautifully. And then we avoid having to harvest any autogenous blocks for this teenager. Again, you can see the papilla sparing releases. And again, always important to reattach that area first before suturing over the crest. Okay, 2 more cases. This case has been a very difficult one. This patient came to me. It's been several months now. She had a long-standing bridge that was failing from 5 to 8. She only had teeth 5 and 8. 6 and 7 were extracted some time ago. You can notice in her, she's in her early 30s. Significant soft tissue defect, vertical defect, not the healthiest keratinized tissue. Really just a difficult case. A lot really scarred down tissue. Um, and so I figured with the defect that we had, I needed to use something that was going to be non-absorbable just so I could have better space maintenance and volume stability so that I could try to get more of a vertical gain. And so you can see the defect here. Um, both pretty significant vertical and horizontal defect. In this case, I decided to use OraGen, again, mixed with some of the Salvin 7030. And then also Allospar, which has a ton of growth factors in it. Because I really wanted to try to basically throw everything I could at this case, to get as best of a result as we could. So this is a titanium reinforced PTFE membrane. I have definitely a love-hate relationship. The ones that heal well really heal nicely. And in the past, the ones that don't heal well typically get exposed, they get infected, they get kind of nasty. You take them out and the case has kind of failed and you're having to regraft. So here's tacked on the palate first, and then I tack it on the facial. Pretty good. I think it looks very nice. I usually will put a collagen membrane over just to separate out the fibroblast from the osteoblast, make sure we don't get any soft tissue ingrowth once we go to uncover and remove that membrane. And then if you look here, I mean, I looks pretty good, like tension-free closure. There's no gaps there, right? I have a little video here. You guys can see the release that I did for this case just to kind of see how much soft tissue release I had. Right, so I show some of these videos sometimes, and I like to show you that usually you should be able to take, your pickups with teeth, and it should extend almost over those adjacent teeth, and that's sort of my guide, knowing if I have enough flap release. So post-op Panorex looks great, right? Beautiful bone, really nice height, lots of tacks. You can see the titanium par. I mean, everything just looks great. She comes back in 2 weeks post-operatively and having quite a bit of pain. This doesn't look good. I can kind of see that it looks kind of open at the crest. It's not grossly exposed yet, but I kind of know where this is headed. I've seen this before, right? It's not great. And so I see her once every week she comes in. Of course, more and more of the membrane gets exposed, and we try to keep these as long as there's no infection, which there never was. She did have quite a bit of discomfort. We try to baby these as long as possible, just to see if any of that bone will start to regenerate. And at this point, even if I'm thinking I'm going to have to regraft, the longer I keep that membrane in, if we're able to get any bone to stay in there, then that's less we're going to have to regraft. Eventually, at 5 weeks, she comes in and it looks like this, right? And this looks terrible. It looks pretty disgusting. Patient's uncomfortable. And at this point, I said, look, we need to take this out. It's been 5 weeks. I had actually taken a scan and the bone looked like it was pretty good. So I said, all right, well, let's take it out. I think I've tortured you long enough. We'll take it out. And so I numbed her up. I only released the tissue enough so I could get the membrane, basically release the tax and get the membrane out. So this is what it looks like when we're done, right? And it's almost basically like you can see the graft, but there is almost like a very superficial, like periosteal, pseudo-periosteal layer that's on top of that graft. And so this is how she left. I didn't resuture anything. We left her like this. Um, we just kind of irrigated it with some saline. I said, all right, like it should start to feel better. I'll see you next week. Let's see how it looks. She comes in 1 week later, and this is how it looks. Literally 7 days later, so you can see obviously some of the bone chips. So I gently take a cotton tip applicator and some Addison forceps, just remove some of those chips. But you can see like man, like there is a nice layer of tissue that's starting to kind of come to heal over that graft. I see her another week, and now it looks like this. I said, okay, well, it's looking better than I thought it would look, right? So we kind of baby it along. 6 weeks out, looks like this. And so at about 3 months, I said, well, let's get a scan and just kind of take a look and see what the bone looks like. At this point, I don't think it's going to be worth waiting 5 to 6 months. I've already removed the membrane. Let's see what it looks like. And surprisingly, and I think this goes to show just the strength of the OraGen, possibly some assistance with the AlloSpark. But I mean, if you look at that scan, like the bone really does not look too bad, especially with how horrible that exposed membrane looked. So the plan for her was always to do a single implant in 5, and then a bridge from 6 to 8. And so at around 3.5 months, which is where this picture is taken, we went back in, and the bone was actually pretty decent. I was able to get the 3 implants in as planned. And And then I just added, you can't see the picture well here, but I did add some more OraGen on top. I also did a connective tissue graft on the facial just to try to increase the tissue thickness and got everything closed up, got primary closure. I've now seen her back. She's I think she's getting tired. Sometimes in these cases it's difficult to say, hey, like hold on, let me get the retractors out and get them pictures. So take my word, she's healing well. I've seen her now 2 or 3 weeks after this. Everything looks really, really good. I think in hindsight, before doing that initial graft, maybe I would have done a free gingival graft just to try to release some of those muscle attachments that were close to the crest. But we got the 3 implants in. She's healing well. I think this is going to be totally fine. And luckily she has a really low lip line, and she shows maybe 60% of her crowns when she smiles, and so I think we're going to be able to get a pretty nice result. And I'll plan to probably uncover those in a couple months and do a temporary in order to provisionalize it and start to shape the tissue. So, I think this slide was shown earlier, but I certainly think there's definitely some truth to this because I've just never seen a membrane like this get exposed that early and the graft end up being as strong and nice as it was. And so this certainly impressed me, and I think it's definitely a testament to the origin and the lineage committed bone cells. This is the last case. This is probably my most straightforward case. I wanted to show this just really to show you how well I think the product works also from a stability and a resorption standpoint. To be honest with you, I think I had this case. This was before I had the cryo freezer, and we had ordered some OraGen, and it was ready to be used. And I had a big graft that I was supposed to use it for. That patient ended up canceling, and so I had a sinus lift with a couple implants. And so I said, I'll just use it for that case, right? Not to say that you can't. Like in my experience, I would say a case like this with just an open sinus lift and a couple implants, probably not necessary, but of course it works, right? So I did a lateral window here. The crest was pretty good. I didn't really have to add too much thickness to the crest itself. We really just needed some vertical height. So we did a lateral window, open sinus lift. I put the two implants in, packed some OraGen. I believe again it was either I want to say it was a 1.3 because I don't think that we were ordering the 0.7s at this time, mixed with a half cc of the Salvin cortical 70/30, and everything's closed up. And then this was 3 months later. Everything's healed very nicely. And then really just this Panorex I wanted to show you guys on the top. And we've all done sinus lifts. If you're on this webinar and you're listening to this grafting material, I'm assuming most people have done a lateral window sinus lift, but you can just see the immediate post-op Panorex on top. And we have a really nice dome there, tons of bone. And on the post-op one, you can see like we didn't lose any of the bone. Like the same height of that is there. So the volume stability is great, very minimal resorption. The bone turned over really well. And I think again, that goes to the quality of the materials that we're using, where we really don't see much difference in the height from that vertical sinus lift from the day that we placed it to 3 months later. All right, that's it. Pretty on time. Thank you guys. This is my wife and my 3 kids, and they're the reason why I do what I do. If you're not following us on social media, you can feel free to follow us on Face Guys. I post a lot of our cases and stuff on here. If you have any questions about OraGen or any of the cases, feel free to email or shoot me a text. And hope you guys enjoy those cases. I'm happy to stay on and answer any questions that I can.
Thanks very much, Dr. Young and Dr. Wetzel. Both presentations were phenomenal, very helpful for everybody. We do have a couple questions. We'll kick off one that was a question that I had as well, and it was a question on timelines. Somebody asked as far as reentry timelines. You mentioned the 6 months. Can you give us a little bit better range of what you've used OraGen, but also just to kind of help, I think, let us know what you would do with autogenous bone. So you had that case where you showed the side-by-side reentry. The one you said was from scraping autogenous. How many months those were, just to give us all an idea of what your typical timelines are and your observations.
So usually when I do only autogenous, especially if it's not with Cori plates, like if I'm just using particulate autogenous, I usually will wait 6 months. And so what I usually do is I'll see every patient back at 2 weeks. If everything looks great, then I say come back in 4 months and we take a scan. If I see them back in 2 weeks and the tissue's iffy, I may see them back again in another 2 weeks or another month just to kind of make sure that the tissue looks the way we want it to. So I'm usually getting a CT scan around 4.5 months. Now, sometimes I've seen with some of these, if you do grafts with purely autogenous, is sometimes at that CT scan at 4.5 months, it doesn't look as dense as you would like it to. And so sometimes, like I've always just been like, yeah, let's just wait another month or two. So I usually will wait to 6. What I've noticed with the OraGen is these cases that I see at 4 and 4.5 months, like the bone is dense, it's opaque on the scans. And so at that point, usually at the 4.5 months, I'm telling the patients, like, whenever you guys are ready, we can schedule. And it's usually 2 to 4 weeks after I see them, we're usually getting them scheduled. So most of those cases are done around 5 months. Some of the ones that I said were 6 to 7 months later were just, not because I needed to wait more on the graph, but more because the patient just had a trip or they were traveling or our schedules just didn't align. And so we waited a little bit longer.
Very helpful. I think it helps a lot of folks. I know we're in an era where everybody wants it yesterday. So
Right.
it's good to see that you're patient. I know I'm guilty of that sometimes, rushing it along. We've seen some nice results really early on, but clearly waiting longer would be good.
Yeah.
The next question is kind of for both of you, and I would like Dr. Wetzel to start it, and then I'd like you to comment on the clinical side. And basically, it is the addition of the 70/30 that you're adding. And it sounds like you do that on a pretty regular basis. So I think it would be helpful, Dr. Wetzel, if you put it in perspective and you can give us the percentage of the fibers that's in it now and the percentage of cortical that's sort of in the product as it comes. And then maybe give us a little comment on your experiences, because I know it's shifted a little bit with some of the different iterations. So maybe you can kind of give us your thoughts on that and then carry it into the clinical side as far as what's the maximum you've added. You mentioned basically the 1.3 cc plus a 0.5 cc. Have you gone further than that as far as maybe more like a 50/50? And so comment on the kind of the clinical blend. I'm going to say that typically I try not to add, but your results are fantastic. And that added density may be good because there is a pretty big fiber component, which is the demineralized, and that can lead to slumping. It can lead to a little bit less density. So, maybe having some of that may be a real bonus, but I'd like to kind of hear Dr. Wetzel's comment scientifically and then throw it to you for your clinical experiences on that.
Yeah. Good question.
Yeah, but it certainly doesn't hurt anything to extend the grafts a little bit. We see surgeons do that all the time. Adding, so as it comes, it's about 70% of those fibers and 30% of the corticocancellous chips. So it has about the consistency of a crab cake, I would say. Yeah, if extending it to get more volume is great. We'd see people do it with the fibers like osteofiber. If you want to get more of that moldability kind of thing going on, or if you want to get more of that space maintenance, then adding the particulate is also a great way to go. Also, it certainly doesn't hurt anything to add a little bit more to it to sort of bulk it up to give it a little bit more of a crunchy consistency if you want, and to help fill up some of the spaces that you're trying to fill, for sure.
Can you comment on if you guys have looked at other percentages? In some of our previous discussions, I think you guys had chatted about different instead of the 70%. Have you looked at others? I mean, I guess where I was wanting you to go a little bit, not too heavy into it. It's late at night for some people, and science, can put them to sleep. But the demineralized fibers have a big advantage in the sense that's shall we call it one of the osteoinductive components of the graft material. So I think
Yeah,
sometimes people underestimate the benefit of having the fibers there, and that's why you guys
yeah,
added that back in, so that each component has a positive. when you're adding that cortical component, it's depleting the fibers, but yet from a scientific standpoint, there's a lot of pluses with the demineralized fibers. So I was kind of looking for
Yeah.
something along that line.
Yeah, for sure. And those fibers really are kind of special. And these are the same fibers that are in osteofiber and osteofiber plus. They're demineralized fibers. And what's really nice about them is in that form factor, when we put them through the demineralization process, they almost take on sort of a fluffy sort of appearance. In fact, the code name for it was under development was fluffy bone. And it really has this nice sort of collagenous structure to it that really seems ideal for osteoblasts. Osteoblasts are very finicky about the type of surface that they bind to. It has to be just the right sort of surface architecture. And we really kind of lucked out with these fibers in that it just seems to have the perfect surface architecture for osteoblasts. They love it. And when we look at it histologically, like when we look at the clinical histology of it, you can just see the osteoblasts just gathering around those fibers and starting to mineralize out from the fibers. So the fiber component, as you say, is very important. It adds a very nice edge to the graft, if you will. Yeah, for sure.
Thank you.
Yep.
Yeah. So, I think it's interesting, that I guess I thought it was 50/50 when I first learned about OraGen. In my experience in using these, maybe it's more equal in the point 0.7 and the 1.3. I've noticed it does seem like it's 70 to 80% fibers, and sometimes I don't feel like I have enough of the corticocancellous chips. Now, some of this goes back to when I had done some grafting cases early on in my career when I tried to use just some demineralized fibers alone without anything else. And I never liked how I feel like when you use that alone, the material almost it kind of swells a little bit. It's difficult to compress. You try to kind of compress it into a space. If you think you have a 1.5 or 2 cc defect, you take a half cc of the fibers, and sometimes like you can't even get that in the space because it just springs back and it almost carries too much volume, but you don't actually know what's all in there. Like it's the fibers, but like how much of that is going to stay and remodel and turn over into vital bone. And so I've kind of found that I'd like to have more of the corticocancellous chips almost as like a volume stability thing where I feel like it makes the OraGen or the fibers almost handle a little bit better. It's not as spongy, it doesn't swell as much, and I feel like I'm almost able to kind of pack it in there more. I don't know. I feel like when I've done cases before, you take a scan and you just see these fibers alone and it looks very lucent. Sometimes 4 or 5 months later, I just don't see that it turns over into something that looks very dense on the scan. So, I don't know from a scientific standpoint how much that makes sense, but when I add some of the cortical, we know that the demineralized fibers tend to resorb a little bit faster. So my thought process is using the 70/30 cortical as I'm using now a slower resorbing material that's a little bit more dense with the cortical chips. Gives me a little bit more of that radio density on my CT scans, and I just feel like it stabilizes the graft better, and it also helps it handles it better, and I can kind of condense it better.
Well, the results certainly speak volumes. It's really beautiful results, and that seems to be what you did, fairly consistently. What would you think about just adding cortical as opposed to the 70/30 blend? Any thoughts on
Yeah, I think it'd be
positives,
fine.
negatives, or
No, I think it'd be totally fine. Like it could be all
and then what
minimal.
particle size?
I usually get the small size. Yeah, like 'cause some of there's already usually some chips that are in the OraGen. Sometimes they're kind of chunky, or I think the bigger the particle size, it sometimes doesn't turn over into bone, and sometimes it sticks around like a foreign body. So I'd rather those particles be smaller.
That's great. Another question was on contour grafting, and you showed a couple of interesting things. One, you showed the porcine collagen that you're adding at the uncovering, which in some respects may do two things for you, the positive on the soft tissue, but it also may act as a little bit of protection from the periosteum. Some of these highly reactive grafts like autogenous and the cellular bone allografts can resorb when you flap them, right? The periosteum can be pretty aggressive. You obviously showed a lot of volume in yours, but maybe if you didn't have quite the volume, do you do much in the way of contour grafting if you think you need it volumetrically? The one case you actually added more OraGen too, but xenografts might be a little better from if it's strictly contour based. Do you want to maybe comment to just contour grafts in general following OraGen, or maybe some of your other cases as well?
Yeah, no, I don't think I showed, too many here. Like one of the things that I've learned in my career, and some of these, I have a pretty young career still, but some cases just require a second graft. And I'll tell some patients that up front. And some people ask like, well, what do you charge? Like let's say at the time I open it back up, I'm putting implants in, but I really want a little bit more bone, so I'm burying the implants and adding more graft or adding a contour graft just to try to bulk things up a little bit more. I obviously don't charge a second time for the grafting at that point. They're paying for the implants. Usually in those cases, like I'll just use like an allograft sticky bone most times. I haven't been using much xenograft to be completely honest with you. Um, I don't have a great reason for it. I listen to some of the ITI stuff, and I know some of the guys, don't, they prefer not to have xenograft in contact with implant surfaces. Obviously, for contour grafting, I think that's different, and I think that's one of the reasons why some people like to do that sort of layered technique with having the allograft closer to the implant and then doing the xenograft over top. Um, but yeah, I think, there are certainly a lot of guys that do it that way, and it seems to work well. Um, I haven't used OraGen necessarily for contragrafting. Like usually it's just if it's like when I'm just looking for the best result and I really want a good bone regenerative result, then I'm like, I'm gonna just go the extra mile and use OraGen and not just use allograft or not just use sticky bone. I need something a little stronger.
Sounds good. One last question, and then I think we'll let everybody off the hook here. And that question was regarding exposure. If you do have a case open up, you kind of showed us the one opening up with the PTFE membrane, but just from a general sense, obviously you're getting really good release, and I think you've made a clear point. That's the most important thing. But do you want to comment on any thoughts? Somebody just was asking about incision line opening and maybe how often that happens to you. With excellent tension-free closure, it may not happen very often, but if it does, what your management is for that. And maybe it's not, maybe this would be for more the collagen membrane examples you gave, rather. You already kind of showed what you did for
Yeah, sure.
the dense PTFE.
Yeah, I think that's everyone's biggest fear, right? In tackling bigger grafting cases is like, can I get adequate closure? And that's why people don't like using titanium meshes and they don't like using non-resorbable membranes because they're afraid of the suture line, opening up. And it happens to everybody. Luckily, it happens far less for me now than early on when I was doing these. And like I showed that one case over the mental nerve, I think really learning how to do a true proper periosteal release, like an urban style technique, and knowing all your zones of the lingual nerve on the lingual side too, and releasing a flap on the lingual side, that's really made it a big difference. Like you gain a whole ton of confidence in doing these cases when you know you can get tension-free closure. Now, of course, like, that case I showed where I had that exposure, like sometimes it happens in hindsight's 2020, and I definitely would have managed. That's a case that I would have tried to manage the soft tissue first, like with how scarred down and how tight her muscle attachments were on that crest. But I think that's the beauty of doing a collagen or doing all resorbable stuff that like if it opens up, I mean, usually you don't have to do anything, right? That's what native collagen membranes do. They degrade faster when they get exposed. They're usually pretty biocompatible. They don't create a significant and surrounding inflammatory reaction. And so I think it's just one of those like if it's grossly infected, then patients need antibiotics, maybe some Paradex, see them again in a week. If it doesn't work, try switching an antibiotic or adding a flagyl or adding a third generation cephalosporin or augmentin for another week, something that's a little bit stronger. If things are just not getting better and you're 3, 4 weeks out, patient's still swollen and it's draining. I mean, I haven't seen that happen yet. But at some point, then you probably just need to just take everything out and wash it all out and get rid of everything. But I haven't seen that yet with any of these OraGen cases and using resorbable membranes. I think that happens very, very rarely. And if you do have it open early on and eventually it starts to close 5, 6 weeks out, that's probably a good time to get a CT scan and see if there's any bone in there. And if there's not, then you can prep the patient early on. Hey, look, like let's give it another month or so. I'll repeat another scan, but it kind of opened up a little early. You had a mild infection. Like there's a chance we may have to, regraft in a couple months and at least put that into them early on. You don't want to make them wait 6 months only to know that the scan's not going to have any bone and they wasted all that time and now they have to go through it again. So.
Great points. One last question kind of dovetails into this that I missed. And that was when you decide to use tax or not. I pretty much saw that you use tax almost on all of them, but somebody did ask that, and I assume that would also kind of apply to incisions opening and tension-free closure, that you're stabilizing most of these membranes. Is that correct?
Yeah, I noticed a pretty big difference in my results when I started securing my membranes. And there's obviously a lot of good studies out there about graft stability and securing membranes and the difference in vertical gain. For me, sometimes if it's in a maxilla, just the angle, I think you can, it's really taught that you should tack the most difficult area first. So in the mandible, that's the lingual, and in the maxilla, that's the palatal, right? So you can really pack it on top of the crest first, and then some on the facial, and then kind of swing your membrane over. In the maxilla, I can usually get tacks on the palatal part. I don't find it too difficult to get them on the palate. On the lingual side, I've tried it. I've used some of the angled ones to try to tack it, and then you lose the tack, and now it's in the floor of the mouth, and you can't find it, and you're worried about the lingual nerve. And so I've just been like, let me just change my technique. I tack 3 on the buckle. I pack it like it's a pocket. I swing the membrane over, and then maybe you don't have to. I just find that putting those periosteal sutures just helps to keep that crestal aspect a little bit more immobile. And we know that, graft immobility and graft stability is really key, especially when these cases need some vertical height.
Fantastic. Well, I'd like to both thank you, Sean, and thank you, Brad, for great presentations. And I think this really helped people see some potential of what OraGen can do, and reminded people of how it's being used in a lot of other areas of orthopedics. As Brad showed, it's a material that's been around for quite some time, and it's exciting that they've put the energy into sharing it with the dental field, with Salvin being able to distribute it and help us with freezers and just make the whole process go smoothly. So with that, I'd like to say good night, everyone, and keep an eye on your inboxes. We will announce our next webinar in the not too distant future. So good night from now, unless anybody else has any other comments.
Thanks a lot, Brad, for hosting.
Great.
I appreciate everybody being on here.
Yes, thank you.
All right. Good night,
Thank you,
everyone.
everyone.
Have a good night.
Take care.
Bye-bye.
We hope you enjoyed this presentation of Spark Study Club. You can receive CE credit for this lecture by visiting sparkstudyclub.com. Thanks again for listening, and we hope to see you again soon.